to our conversation titled Compassion in Digital Mental Health. In this episode, Daniel Buchman, bioethicist and independent scientist from the Center for Addiction and Mental Health, and Nelson Shen, scientist, also from the Center for Addiction and Mental Health, discuss their research into patients, privacy, organizational compassion, and machine learning technologies in mental health.
Hi, I'm Nelson Shen. I'm a scientist at the Center for Addiction and Mental Health and assistant professor at the University of Toronto at Institute of Health Policy Management and Evaluation. I'm also a 2021 AMS Healthcare Technology and Compassion Fellow.
And I'm Daniel Buchman. I'm a bioethicist and independent scientist at the Center for Addiction and Mental Health in Toronto. I'm also an assistant professor in the Dalla Lana School of Public Health at the University of Toronto and a member of the University of Toronto Joint Center for Bioethics and a 2020 AMS Healthcare Fellow in Compassion and Artificial Intelligence. So it's so wonderful to be able to sit down together today, Nelson, and have a chat about research, which I love talking about all the time. So tell me, tell me about your work.
Yeah, I completely agree with you, Daniel. We've been collaborating on a few projects together. We never ever actually sat down and talked about what we actually do with our research other than the projects we collaborate on. So
I know, and I think actually it's kind of weird, and that might be a product of the pandemic, where we're all doing this remote work so often that we don't have those natural spaces in the office anymore or going for coffee I don't think you and I have ever actually sat down in 3D, which is really unfortunate. Anyway, I'm glad to be able to speak with you via Zoom today, but yeah, I think, we haven't had a chance to sit down, so let's use this time the best we can.
Yeah, for sure. And we'll get together once we can. I'll talk a little bit about my research. So my background really is in health informatics, and I did a PhD in health informatics and health information systems. And one of the things that I've been really passionate about in leading up to it was the idea of giving patients access to their records, really to empower them and activate them to become better self-managers of their care, to make better decisions. And along the way, during my PhD, it was suggested that, why don't you look into privacy? What does privacy mean to you? What does it mean to the patient? And, privacy is often being positioned as this barrier to any sort of innovation. No, we can't give our records to patients because of privacy. That was something I found quite interesting. And, as I dug into it, I found that there is a bit of a divide between what the privacy discourse is in healthcare and what patients actually think. And, a lot of it oftentimes comes from a top-down sort of mentality where it's really based on what the healthcare community, the different perspectives in the healthcare community, but often it leaves out the patient perspective. So for my dissertation, I really looked at, what is the patient perspective on privacy in the context of sharing their information through digital health innovations. Since this podcast is supposed to be about mental health, one of my studies was in context of mental health. And so I spoke to patients about, what does privacy mean to you in context of exchanging digital information in provision of care, for use for data research and analytics, and also for consumer type products. And, I heard something completely different than what is commonly in the discourse, where, mental health information is super sensitive and has to be locked up. Whereas my study found that, there were concerns amongst patients about their privacy. However, that really didn't amount to much. In terms of their willingness to participate and share their information, a lot of them thought it was a no-brainer to share their information especially for those secondary uses, of which I hate using that term, for data used to improve treatments, for research, for health system allocation. So it really demonstrates there was a bit of a gap there. I think we're starting to understand. And, one of these things which kind of drives me crazy, and my pet peeve about privacy research is this question that is always asked in surveys is, how concerned are you about your privacy? Or, are you concerned about your privacy? And then they report it as, X% of people are concerned about their privacy. That's why we shouldn't do this, or this is a barrier. However, there's a lot more nuance to that. And when I look at that, I'm like, that's a really interesting reaction. But what does it all mean, right? And in my interviews with these people affected by mental health conditions, there's this pragmatic idea. In order to get the best care possible, there needs to be good data. I think most of the population understood that, and that's why there is this willingness to share. And there's also this idea of privacy fatalism, where now we're in the state where we have minimal control of our data. And if hackers really wanted to get to it, they could. So what can we do but trust?
Actually, going back to something you said earlier on when you were describing your research, which I've always found really interesting, is the idea that because of privacy issues, we can't actually share your health information with you, which is always as a really interesting thing, because it's like, well, whose information is it? And whose data is it? And I'm not thinking of data like, the data that I put on my phone, but my personal health information that I can't even access myself, or actually I can access with lots of difficulty perhaps, and lots of barriers. And so these issues around privacy and access to records and the specific nature of mental health privacy comes up a lot in my own work as a bioethicist when discussing ethical issues that come up in patient care, whether it has to be about access to records or information or people's willingness to share information, and just the intuitions that people have about privacy, or even have clinicians' intuitions have about the need to protect privacy. Of course, patients have a right to privacy and there's a duty to protect confidentiality. I agree that there might be a tension here in that discourse between what we think people want, or what so-called experts recommend, and in what patients are saying.
Yeah, I completely agree with you there. There is this tension there. And I think it's really rooted in how we historically approached it. Privacy is often grounded in case law. And if you think way back to this idea of right to privacy, you have Brandeis and Warren in their right to be let alone. That came out of the invention of a camera and people taking random shots and putting that in newspapers. It's evolved quite a bit since then. And a lot of these perspectives no longer, still relevant, I think, this idea of being left alone, but we shifted our view of privacy more towards this idea of control, given the ability to control who gets your information for what purpose and when. I think we have yet to get there. We still kind of treat privacy as this right that we need to uphold. I think there is a shift from what I'm hearing in my conversations with regulators, that we need to kind of start thinking of ourselves more as stewards than as guardians of this information.
I really like that idea of stewards, as stewards of information, stewards of resource, because that puts certain responsibilities, I think, on different actors, whether they're clinicians or organizations, and perhaps also even might strengthen the case for increased sort of regulations over the control and distribution of privacy. I want to get to trust in a moment, because I think that's an area actually where we both have some interest in. But getting back to the tension or the disconnect that you're seeing in your work between what the literature says about privacy and what patients are saying about privacy, is that, and this is something that I've struggled with a bit, and not just in this area, but in other areas of mental health or substance use work, or even just differences when we invite people to tell their stories about their perspectives, is that I am fully on board. And I think it is critical that we understand what people think, people who are most affected by a particular issue think about an issue. There's no question about that. We ought to know that. That ought to be engaged in a meaningful way, and really be very thoughtful about how we integrate that into policy. But as an ethicist, I value that as an ethicist, but I also, and as a researcher, but I also wonder, what if people have opinions about things that could be harmful? Or what happens if people have opinions about things, let's say about their privacy or about sharing information, that may actually be against their interests? So how do we balance that? And in a context like this, I'm thinking of, okay, so you mentioned that there's something sensitive about mental health privacy, mental health data. And I would actually agree. And I think because if we see about the history of stigmatization, how stigmatized mental health is, and that's, again, another area of research and interest of mine, I think we ought to be sensitive about this data. What if people want to be more liberal in the sharing of their data? Perhaps for very good reasons. I'm not criticizing that. But then again, we're in a situation right now where there's a lot of third-party commercial interests in the use of people's data. And they may be used in ways that may actually go against their interests and not actually benefit them.
Well, first, I think to your first half of your comment there, I feel that patient engagement in this bit, and I think that's what you're sort of alluding to, really needs to be meaningful in a way that, is not tokenistic, and oftentimes it is tokenistic. But when we do engage, we do have to have that intention in really integrating that input into whatever sort of process or policy decision or design decision that's being made. I think that's the first step. Earlier, I pit these two kind of counter forces of, patient voice and healthcare privacy community voice. I think there's a lot more in there that need to be at this table. And I think understanding that it's just not one controlling, it's not one dominant voice in that discussion. I think we need to approach it with that way. I think it sounds maybe a no-brainer, but that's not how things always work. That being said, there are some great patient engagement initiatives out in BC where they're looking at, well, what are the uses of data and how do we do it? And using deliberation panels where they select a citizen jury and they're provided all the resources they need to level set to make the decision on the behalf of the greater population. That's a really great case example of how we can approach this, where there is a meaningful seat at that table to contribute to the conversation of how data should be used or how it shouldn't be used. And how do we build that process to determine it? And I think this is a good place to plug my AMS healthcare project, where I am looking at, well, what does this idea of consent mean in digital health? How does the deployment of consent or the privacy notices, how does that impact the user's view on the compassion of an organization? Looking at compassion at an organizational level, where it's the response to suffering and the trust related to that response to suffering, where trust is defined. Well, in my case, I operationalize it as, is the entity benevolent? Are they competent? And do they behave with integrity? So how does rolling out some sort of consent where no one can understand, where you just scroll to the bottom, and I know we all do that, and just click agree, how does that impact the user or the patient perspective on the compassion of organization?
I really like how in your work that you've been linking compassion here with trust and trustworthiness, especially trustworthiness of organizations, and some of the virtues or the characteristics that you mentioned of a trustworthy organization. And I think that is so critical for all of healthcare and beyond healthcare, but particularly in mental health. We know from our own experiences and from decades and patient, client, family experiences, and just in tons of research too, a lot of people who are living with serious mental illnesses, who may have also other intersecting identities along various axes of social inequality, who might be disadvantaged, do not trust healthcare professionals and do not trust healthcare institutions. And I would say for very good reason. In many cases, they themselves have been harmed, or members of their families or communities have been harmed. And so I think it is a responsibility of healthcare institutions to demonstrate trustworthiness in the sort of the ways that you're mentioning, particularly for structurally vulnerable groups, including the people who are living with severe and persistent mental illness and people who use drugs and in general, but also when it comes to something like consent and digital technologies. I agree with you, if this is sort of where you're going, is that in order for care to be compassionate, we as organizations have to demonstrate trustworthiness. In some of my previous work on trust, I was taking a perspective from sort of medical sociology, but also in moral philosophy, and just how, when we trust, we make ourselves vulnerable, right? And trust is very specific. So I can trust you, Nelson, to edit my paper for me, because I think that you're going to do a great job, and you're going to not leave my paper worse off or something like that.
I'm glad you feel that way.
I have confidence, a high degree of confidence in your ability to do that. But I may not trust you to mail a letter for me. Not that I have a good reason for that, but perhaps my point is that trust is specific, right? So I might trust you to do to A, but not B. And let's say it was like a really important letter that I wanted you to mail, but you couldn't be relied upon to do it. And then I may have been harmed because maybe, I had to send something by snail mail. I don't know. Nobody sends snail mail anymore, but something by snail mail that was for a hard ink copy of something for another AMS healthcare grant. And it had to go into the mailbox but you didn't send it in by the deadline, right? So I would be harmed by that. So I would make myself vulnerable. And we make ourselves particularly vulnerable, I think, as patients in healthcare and especially in highly stigmatized conditions like mental health and substance use disorders, where we place trust in the institutions and our ability to do what they say they're going to do and not leave us worse off. And when we get to these situations around digital technologies where we are providing our consent to the use of our data, or, as you said, secondary use for potentially other reasons, we are essentially making a trust leap in that the organization is going to protect our interest and not leave us worse off and not harm us. We are making a trust judgment. So, I can imagine in the context of digital technologies, for example, and a context of populations who do not trust healthcare professionals and organizations, and particularly in mental health, may have a lot of challenges with that. And so I think because of those power dynamics between healthcare professionals or mental health care professionals and patients, clients, and families, that there really is that responsibility in healthcare generally, but also particularly in fraud areas like digital technologies to say, hey, we are trustworthy and you can place trust in us and we're not going to leave you worse off.
I really like your point there about, and it reminds me, just taking me back to that study with my conversations with people affected by mental health conditions. And there are certain trust heuristics we use, such as credentials or reputation of the individual, familiarity, relevance of the sharing data, like you mentioned, and history. Those are all factors that we play into our assessment of whether an entity, an individual is trustworthy and if we can become vulnerable to them in fostering that therapeutic alliance, right, so to speak. But I think with technology, it's so much different because then it's something unknown, especially as we kind of forge ahead and look at AI. Oftentimes that's going into a black box and you don't know what's going to come out of it. And this idea of familiarity and just even like what you hear in the news, like that might have impact on what is going to happen. Like we hear all these horror stories about how AI has been misused and distrust. There's a lot of distrust there. And from my research, I found that the further you get away from the point of care, so your doctor, then maybe like the hospital, then the healthcare system, then, academics, and then commercial, like there's less and less trust each step along the way. And now we're expecting people to trust this idea of just throwing your information into this black box and, hoping something good would come out of it, especially in light of, all these scandals that we've seen. Like, I think that's a very scary proposition for many individuals.
If you find these conversations interesting, check out the AMS Healthcare website at amshealthcare.ca. There you will find information about our various funding programs, our 39 funded grantees and fellows in AI and compassion, and a wealth of resources on compassion and technology in healthcare. Now back to the conversation.
I know we both kind of dabble in the field of AI, and I think this would be a good place to kind of talk a little bit about your study and the potential impacts of that.
For sure. So my AMS project looked at how healthcare professionals, so interprofessional healthcare professionals, engage with AI or machine learning technologies in mental health and substance use care. And what was really sort of premised on this idea was that there's a lot of hype around these technologies. There's a lot of expectation. And we see this in the news and in some of the literature as well. It's like somehow we see terms like it's going to revolutionize healthcare. It's going to be a paradigm shift, right? And perhaps in some ways it might. And I think in some ways AI and other digital technologies may improve diagnostic accuracy, treatment prediction, and so forth. But there's a lot of hype. And so I was less interested in the ability of the technologies to actually do it and more in somehow the perception of them and their ability to get close to the truth. I was also interested in how this might influence perceptions of stigmatized populations like people living with mental illness and substance use disorders. I was inspired by some past research that had looked at biological explanations or understandings of things like mental illness and substance use disorders. So there's been a push over the last number of years to say, hey, if we could only understand schizophrenia as a brain disease specifically, or addiction as a brain disease, we'll reduce stigma. And stigma is so harmful that only if we could image somebody's brain, for example, using neurotechnologies, we would show that the condition is real in a material way. And this will reduce stigma, it'll improve treatments, and increase access to care. All really, really important things. But that actually hasn't panned out. So there's, again, a lot of hype around these kinds of technologies too. In the social science literature, we've also seen situations where participants were given vignettes describing, someone, let's say, the explanation that schizophrenia is a genetic disease or addiction is a brain disease or something like that. And this is not to say that there isn't just important genetic components to any of this or that biology is not important. It is critically important. But then they gave people these surveys and asked them to rate their levels of stigma and also something called social distance. And social distance is the degree of familiarity or comfort you might have with someone else. So, for example, I might be comfortable with someone being my next door neighbor, but not as a member of my family. I might be comfortable taking, carpooling with them to work in the days when we used to come into the office that way, but not as my sibling. So there's different degrees of comfort and social distance. And this research found was that actually with like genetic technologies and imaging technologies, stigma went up. And other studies found that compassion and empathy went down. And this is very counterintuitive, because if we had a biological understanding, or if we had this understanding, isn't it supposed to reduce stigma? But it's been a very mixed message in these studies. And so I was wondering, given the hype with these AI technologies out there, what might this happen with machine learning technologies too? So what we did is we did a survey, and we recruited over 300 healthcare professionals, interdisciplinary healthcare professionals from Canada and the United States. And we gave them 3 different vignettes, but they were randomized to one of the vignettes. So they didn't know there were these other conditions. One condition was about a person either diagnosed with schizophrenia or an alcohol use disorder. And they were predicted to develop this condition either by an app, like a machine learning app using natural language processing. The other condition was brain imaging to compare it. And then the third condition was what we do normally, like a psychosocial history, so family history and so forth as a comparison. I'm not going to say too much about it because we haven't published the results yet, but I can say that there was a statistical difference between the groups. It wasn't mainly in terms of stigma and personal responsibility. There were some things that we found that we were a little surprised about that we didn't expect, but there is at least a statistical difference with this group between some of these different conditions. Now, does hype have around the perception of the technology? These are all experimental technologies. People are really interested in integrating them into clinical settings. Might that influence how we do this? Perhaps. I think at least with the study, again, I don't want to say too much because we haven't published it as of this moment, but we're working on that. But I think, our findings do have important implications for understanding how healthcare professionals do engage with this technology around issues of stigma and mental health. And at least the perceptions of it, or at least the perceptions of what we think, or what healthcare professionals may think the technology is able to do for us. And I think that's really noteworthy. There's not that much research that is looking at this as of yet, although literature is starting to grow. So we're happy to be able to make at least a small contribution to that growing literature. But I think from a real practical perspective, when we think about compassion and technologies, and for many of the reasons you've already said, Nelson, around trust and trustworthiness and just how we engage with people, mental illness and substance use disorders are so highly stigmatized, and people do not receive compassionate care on the whole, despite even best efforts. Of course, there are instances where people really do, and there are organizations and individuals doing excellent work in this area. But on a whole, we know this to be true, unfortunately, and so we need to change that. And so I would hope that the technology and any integration of AI or machine learning technologies in healthcare would actually increase compassion and reduce stigma and not have that unintended consequence. So that's what we're looking at, and that was the project. I'm also involved in some other really interesting areas, similarly around risk prediction in psychiatry and risk of violence and risk of aggression, and using machine learning to do so when we know that a lot of these big data sets are trained on biased data that are biased towards race and gender and other sort of conditions. So one question that does guide my work is, how do we create fair models? How do we create equitable models? How do we do that in the interest of passionate care?
Yeah, that's a very fascinating project. And, I think what really strikes me was, this idea that by using AI and going with really objective biological explanations of whatever sort of mental health condition it is, it's not really doing what it's intended to do. And maybe would it be because I'm just grasping straws at this point? Is it because we're might be dehumanizing the experience, and the story is lost with that, or any sort of kind of explanations on why that might happen?
I'm not sure. I mean, it's one study and only one study, and I think a lot more research has to be done. I think some really interesting qualitative research on this would help provide more rich and thick descriptions about what people are thinking about and their reasoning, right? It's hard to, I don't want to jump to too many conclusions based on sort of one survey study alone. But you use the word dehumanizing. I think that's absolutely true. I mean, dehumanization is central to the stigma process, right? I mean, directly tied to compassionate care, or lack of thereof, rather. Is that happening with AI and digital technologies? I don't know. At least what we found in this survey study is that some of the findings are actually quite consistent with the literature on healthcare professional stigma towards people with a substance use disorder, which is high, and that the technology actually may not mitigate that. The potential integration of AI and other digital technologies into mental health care, has many objectives. So I think really you need to understand both the good and the bad and the ugly, I guess, of all of this in order to be able to refine our approaches. One thing I actually want to add to all of this discussion is that we shouldn't, at least in my opinion, rely on technology. And I'm using technology very broadly here, right? I'm not just talking about, digital technologies or AI, but to help us solve social problems. I think maybe we touched base on this at some point earlier about this, is that I think we live in a very, I don't know if the term is technophilic society. We love, especially in the global north, we love shiny new gadgets. We love new tech. And that's also around brain imaging. Like, oh, finally, we have this we can see inside the brain. It can tell us what's really going on. We can get the truth of the matter, but it's not going to solve stigma. Every major hospital is not going to improve with having a brain imager, is not going to improve access to care. We have these social and structural and policy related issues, which are not the sort of material technological, perhaps. We need a social solution to social problems, I guess is what I'm saying. But I think technology can have a role, but it's not the self.
I completely agree with you there. And anyone who's taken my courses have heard me rant on about technology. And these are health informatics courses, right? Where it's about technology.
Right.
I rant on about how technology isn't the solution to our problems. We often just think, with our greatest intentions, if we do this, throw this technology in there, we're going to solve this problem. We'll solve stigma. But no, it isn't. And, I really encourage people to start thinking about it from technology. And these are health informatics courses, right? Where it's about technology.
Right.
I rant on about how technology isn't the solution to our problems. We often just think, with our greatest intentions, if we do this, throw this technology in there, we're going to solve this problem. We'll solve stigma. But no, it isn't. And, I really encourage people to start thinking about it from the true needs are. Where are the pain points? Where are the issues? And then develop solutions out of that. And then figure out how do we incorporate technology into it, rather than just trying to squeeze it in there and just try to make it work. And, oftentimes in the past, that's why we've failed. That's why it took so long to get the electronic health record up. You just kind of top down, we're all going to do this. This is going to change everything. It took us a long time to get to the point we are today. And, I think that's a fallacy, a way of thinking. I really think we need to start embracing other approaches to this, where it is, and going back to our discussion about privacy and what should we do, what shouldn't we do, having everyone around the table so that we can figure out what the problem is and get to the solution together, rather than prescribing it to individuals.
So much of what you're talking about reminds me of the work we're doing in the Brain Health Data Bank, our study around consent preferences, and really understanding what people want and what model of consent they want in terms of sharing their information, particularly among people who are living with mental illness, and how they may think of their own data and the privacy-related issues, and what kind of model do they want? Do they want to give it all at once, their data? Do they want to do it by a project-by-project basis? Do they want an opt-out sort of dynamic consent model? So I'm excited for that work we're going to be doing together.
Yeah, me too. I look forward to future conversations with you. Maybe we don't have to just talk about that project and can gab about, all the great things we talked about today. Thank you, Daniel, for this time. And thank you, AMS Healthcare, for providing this platform.
Absolutely. Thanks, Nelson. And thank you to AMS Healthcare for giving us the space to do this and have this chat. And I look forward to continuing the discussion.
Thanks for joining us for this inspiring conversation on the importance of compassion in digital mental health. And a big thanks to Nelson and Daniel for the great discussion. Please connect with us again for the next AMS Healthcare conversation on good tech, compassionate healthcare.